Good afternoon, all who are present here. And today I'm very happy on behalf of S.I.C College of Physiotherapy to introduce the speaker, an expert in physiotherapy field, then Mr. Pradeep Shankar, who has got 20 years of clinical and teaching experience. And he'll be presenting today on physiotherapy intervention in scapular dyskinesis, a clinical perspective. And it is, we are very happy to have you here, Mr. Pradeep sir. We welcome you, sir. And to introduce Pradeep sir, Pradeep Shankar, he is a licensed physiotherapist who is presently working as a physiotherapist in ambulatory healthcare services in SEHA, SCHA, Alqua Healthcare Center. And he has held various posts and both in India and abroad. He was an HOD, head of the department, that is in Department of Physiotherapy in Medeor Hospital in Abu Dhabi. So it is he's got an experience of 5 years. And apart from this, and also to Pradeep sir is not new to S.I.C College of Physiotherapy. So he was working as an associate professor from 1999 to 2014. So he was very closely associated from the inception of the college till 2014. And he's held various posts in Rajiv Gandhi University of Health Science. He was a board of studies of chairman for both UG and PG from 2012 to 2015. Apart from this, he was a chief physiotherapist and ergonomist in Infosys. And also he has served in various sports clubs in Bangalore as well as in Mysore. And to his credit, he has got various awards. He has got a significant contributor award, which was awarded by Indian Association of Physiotherapists for his excellent service. That was in 2013. And also he was awarded as a significant contributor award in Medeor Hospital, Abu Dhabi. And he has got Scroll of Honor awards from MV Shetty and as well as from the Teachers Association of Mangalore, that is South Canara Physiotherapy Teachers Association. And he's got an Excellence Award from Infosys. So we have a lot of awards, and apart from this, he has got he has presented papers, and as well as he has published a number of papers in journals, and he has been a resource person for both national and international platforms. So we are very happy to have you, sir, and I know him personally, and we have worked together, and his passion is shoulder. So I want all the participants to actively involve and get maximum from the speaker. So it is a very good opportunity to have sir with us, speaking with us on this day. Thank you very much, sir, for being with us, and welcome. And I hand over the session to you, sir. Thank you. Pradeep sir, you can take over, sir.
Yes, thank you. Thank you, Vijay sir. It's an indeed pleasure and honor to be the presenter for this platform on this international webinar series going on. It's conducted by S.I.C College of Physiotherapy on the occasion of Dr. Paramapuja, Dr. Rajendra Mahaswamiji's Jayanti and World Physiotherapy Day. I thanked Dr. Kavita Rajan, the principal S.I.C College of Physiotherapy, the staff, and the organizing committee for this wonderful the platform, and it's going on in the international webinar series is going on. Thank you so much. And let me start with the presentation. So, physiotherapy intervention in scapular dyskinesis, a clinical perspective. This is my topic today to discuss on with you. Good afternoon, everyone. Thing is like why I choose this topic. If you see this, the pictures, like overhead athletes, like volleyball players, the tennis players, You can, when we see this picture, when we ask somebody, we always think of only on the, if you ask somebody who's telling like he's going for the cocking phase, external rotation of the shoulder. You're telling like something like he's going for abduction and the hitting the ball, or in the deceleration phase where there is a internal rotation of the shoulder is going on. But we never think of the whole shoulder complex when we analyze or when we observe these things. Like we just think of more on the glenohumeral joint region rather than thinking more on the whole complex. In the complex, the important thing is the scapula. And scapula plays a major role for the shoulder. Many times we neglect it and we don't consider on this one when it comes to the observation or the assessment part. So that is what the topic today I'm discussing on. So it's very important to know the role of the scapula when we are treating the shoulder, the injuries or the shoulder rehabilitation part. So when you see these pictures, you can see the overhead athletes where they're going for different phases. They're going for the cocking phase, acceleration, decelerations. But how it is coming? It is coming from the feet. The force is generating, passing through the trunk to the scapula to the shoulder. But which we don't see this one. We always think only on the glenohumeral joint part when we are analyzing or thinking on the shoulder injuries. So before going for this scapular dyskinesis, so we should know the causative factors of the shoulder pain. We know every time like we think like it can be due to the intrinsic glenohumeral pathology, that is capsular or the labral structure injuries, extrinsic muscle injuries or neurovascular structures injuries. But what is big important things to be known is, see, when you see all these pictures, the thrower should be loose enough to throw, but stable enough to prevent the symptoms. So that means if you serve the ball in the tennis play, when you serve the ball, it goes with a high velocity of 1,600 newtons per second velocity it goes. So it should be like strong enough to hit the ball, but you should be stable enough for your shoulder. The stability comes from the shoulder where we always think stability of the shoulder means is only the rotator cuff muscles, that is extrinsic or the intrinsic other factors like ligaments, capsules and all. We never think about something called the scapula. This is the big deal which we need to think about. So according to the Kibler et al., alteration in the scapular positions and the motions occurs in 68% to 100% of patients with shoulder injuries. That means most of the shoulder injuries, you have the scapular malpositions or the alteration in the position of the scapula. So it's very important to know it then, right? So if you see the, according to Kibler et al., optimal scapular kinematics, that is the movements and muscle function is necessary for the high level throwing and smashing performance in overhead athletes. That means if you want to smash the, overhead athlete, if they want to do the, the good smashing performance, they should have a good, optimal scapular kinematics. That is, the scapula should move in a proper way. That is, three-dimensional movement should be moved proper way. Then only the muscles can able to move, act properly, and the performance will be better. According to the, the Cool et al., sport-specific changes in scapular movement and muscle function has been found in a healthy overhead with possible risk factors for shoulder injury. That means sport-specific changes in scapular movements and function has been found in the healthy overhead athletes. Even the athlete is good, these changes is there, and they are prone to get the shoulder pain. And most of the, the overhead athlete, they have the shoulder pain because of these changes, which is not noticed from the beginning. And according to Cool et al., scapular dyskinesis is associated with the chronic shoulder pain in overhead athletes. So that means most of the shoulder pain in the overhead athlete, there is a scapular dyskinesis associated. And most of the times we don't consider these things. So this is what we need to be known. This is what I'm going to discuss today in the sessions. So like you can see this, according to the Werner et al., and they found like nearly like 68% of the patient is rotator cuff pathology. They have the scapular dyskinesis. 94% of the labral trail are 100% of glenohumeral joint instability. That is most of the shoulder, pathology when you see there is the shoulder instability. So 100% of the shoulder instability, there is a problem of the scapular dyskinesis. So it is important to know this when we want to treat the patient of these conditions. So what do you mean by scapular dyskinesis? According to Kibler et al., it's an observable alteration in the position of the scapula. Okay, and the pattern of scapular motion in relation to the thoracic cage is observable alteration in the position of scapula and the pattern of scapular motion in relation to the thoracic cage. So what do you mean by that normal movement of the scapula? You should know. You know that there's an alteration in the scapular motions on the thoracic cage, but what exactly the normal movement of scapula is very important to know. So before that, you should know something called about the role of the scapula, right? So the scapular stability role is so much like it's an important role. It'll be, consider something like this, the sea lion. If you see the sea lion nose, this considered as like a glenat fossa of the scapula. This is the whole thing is the scapula, and the ball refers to that of the humeral head. So that like the sea nose should be in line with that. That this is the center of line of if the sea lion nose goes away from this, what exactly happened? The ball will fall. Something like this. Our scapular role is. The scapular role is something like scapula must keep the center of glenat fossa underneath of the humeral head center of rotation, and the humerus must not translate excessively away from that of the center of rotations. So that means your center of your glenat fossa should be underneath of the humeral head center of rotation. If the glenat fossa move away from that of the center of rotation of that of the humeral head, what exactly happens? The humeral head either may translate anteriorly, or it may go for subluxations, which may stress on that of the ligaments, or it may stress on that of the structures like labrum and all those things. That means the scapular positions related to that of the humeral head is very important. As I told you, like scapular movement is very important. So if you want to know the abnormal movement of scapula, before that you should know the normal movement of the scapula. So the normal movement of the scapula it's a three-dimensional movement. Like you can't consider like this is the only movement comes in one particular the range or something. It's a three-dimensional movement. It has got external rotations. It has got important called upper rotations and something called the posterior tilt of the scapula. So these three motions is very important whenever you're doing that of shoulder abductions, the flexion and all those things. These movements is very important to be considered. If these movements got changes or malposition, that leads to the something called the scapular dyskinesis. So there may be sometimes the scapula may not go upward rotations. It may go for the downward rotations. Instead of going for external rotations, it may go for the internal rotations. Instead of going posterior tilt, it may go for the anterior tilt. Okay, coming to the I just show you the videos. I want to show the movement of the scapula, which is very important. 1 minute. Can you able to see my video? Okay. So this is what important. If you see the scapula, this is, if you see the scapula, this is the motion is very important. You should know it. One is called the external rotation of the scapula. So this is the external rotation of the scapula. This is very important to know. This is the upper rotation of the scapula. And this is the posterior tilt of the scapula. So when you're moving the shoulder joint, it is very important to know this movement. Like when the shoulder is moving abduction. So it is very important the scapula should go for, the something called external rotation. When you're going outward rotation, and along with that, it's something called the posterior tilt is very important. Why it is very important? I'll be showing you now. Sorry. Excuse me.
Pradeep, sir, can I help you?
Yeah, how to come back, sir? PPT.
So you can go to slideshow, sir. Stop share. Stop share.
Yeah, okay, fine. Okay, sorry. Hope we can see the video presentation now. You can see, so?
Yes, sir. You can just put the slideshow. Yes, sir.
So that's why, sorry, because I wanted to show that motions before going for the slides, because the movement of scapula is very important to be known before going for the next slides. That's what I wanted to show you, that one. So important thing is, you already know about something called the scapular humeral rhythm. Okay, now we'll just correlate your scapular movements with related to the top of scapular humeral rhythm. And you all know, like, like scapular humeral rhythm, it's like we have something called 2:1 ratio of motion. 2 degree of motion is done by that of the glenohumeral joint, and 1 degree motion taken care by that of the scapulothoracic joint. So when it comes to this, the motion, that is a scapular humeral rhythm. So first, the 60 degrees, or when it say about up to the 90 degrees of the motion, 30 degrees is contributed by your what you called the scapulothoracic joint movement. Next, from there, so 90 to above degrees, contribution come from that of another 30 degree by that of scapulothoracic, and the rest of the movement is taken care by that of the glenohumeral joint. So why I want to tell about this is, like you want to know something called the axis when it is when you're doing the abduction, up to 90 degrees and the above 90 degrees. I know you all be knowing it, but I'm just refreshing this one because to know about the root cause for the scapular dyskinesis. See, when you see this, so when you go for that of normally at 30 degrees, you have a line of axis of that of the scapulothoracic joint is comes at the something called at the spine of the scapula. But when you go above that, like 90 degrees above, the axis comes at that of acromeclavicular joint. So this is very important because in the initial phase, the motion is taking care of that of the sternoclavicular joint. But later, when you 90 degree, when you go, you need something called, the acromion should be pushed upward, then only the space will increase in that of the, between that of the, if the acromion process is not gone upward, what will happen? The humerus will start get hit against that of the acromion process region or get impinged. So we need that, the acromia has to move upward. It has to be more upward means the acromia process should be moved upward. It will be taken only when the axis shift from the spine to that of this, the acromia in the acromeclavicular joint when the axis shifts, and there should be something like the force which will try to pull the scapula downwards. Then only the acromia process can move upward. And there will be space for the shoulder to go for rotation and to move upward still more. So what is helping you to push this that acromeclavicular joint to move upward or the acromion to push upward? Yeah, we know there is a ligament stability there, but what is assisting you? It is mainly the muscles. So that means there are some muscles which will assist you to move the acromion process upward. So where is that muscle is coming? It's coming from the part of the scapula. You understood? So that muscle is nothing but the lower traps muscles, the serratus anterior muscles. So something like this, when you see this scapula, when you see here, this is that 90 degree, this is very important when you're going for abduction. See, in the initial phase, the axis of that of the scapulothoracic joint will be at the spine of the scapula. When you go for abduction, it shifts. When it comes to the above 90 degree positions, like this, it has to move towards this side. That is towards the acromeclavicular joint. What is assisting you? And what all the muscle is assisting you? I'll tell you now. See, initially, if you see the momentum of the muscles of the scapula, there are main 3 muscles are very important for the scapula. One is the upper trapezius, your lower trapezius, and the serratus anterior. They are the muscles which plays a major role for these all 3 movements, which now I discussed, something called your external rotations, your upward rotation, and your something called the posterior tilt. So your external rotation motion, your posterior tilt, and the outward rotation is basically contributed by these three muscles, that is upper traps, the lower traps, and the serratus anterior. If you see in the initial phase, the momentum for the, what do you mean by momentum? Its momentum is nothing but a perpendicular distance from the axis to that of the line of action of force of the muscle. So initial phase, you can see the momentum of the upper trapezius is good. The medial trapezius is also more. All the muscles, are more. Yeah, it assists you to move the scapula easily. When it comes about 90 degrees above, there's less momentum for the upper trapezius. But the only muscles, the momentum for the lower trapezius and serratus is there, but the only muscles which can able to pull along with the line of the line of action of force through the axis will be the lower traps. So lower traps can able to push the scapula along through the line of action in such a way that it can assist for the scapula to move away, to move more outward and to push the, the acromion process upward and give a more space for that of the humeral head to move upward more, that is humeral head to go for the more abductions. That means the last degree of motion of the scapula, that is outward rotations, is taken care by that of the lower traps. So that is very important. Why I told you is means these muscles, that is scapular muscles, plays a major role for the scapulohumeral rhythm. So generally whenever we're talking about the scapular rhythm, we just think only on the 2:1 ratio, but we never think what muscles plays an important role for the scapulohumeral rhythm. The scapular rhythm basically contributed by these three muscles. Suppose you imagine that there is a weakness of that of something called the serratus anterior muscles. So that means these three muscles plays a major role, I told you. That is your upper traps, middle traps, lower traps, and serratus anterior. Suppose you imagine that your serratus anterior is weak. What exactly happened to your scapulohumeral rhythm? When you go for abductions, what exactly happens? When the serratus is weak, there is something called your scapular winging will start. That is, your medial border of the scapula will go away, will go up. You'll go away from that of thoracic cage. That means what exactly happening to the scapula? The scapula is going more towards the internal rotations. That means the contribution of the scapula for going for the external rotation is done by the serratus anterior. If this become weak, what will happen? The scapula will go for the internal rotations. When the scapula go for the internal rotation, with that if you go for abductions, what will happen? Is it possible? What exactly happens? When there's a more internal rotation, there is a scapula tends to go more amount to the protraction positions, right? And there's a more tendency for that of your scapula to tilt more towards anteriorly. So when the scapula tends to tilt more towards anteriorly, what exactly happens? Again, the space is reduces at the subacromial region. With that, if you go abduction, can you able to get abductions? No, you will get the impingement. Example is simple. You are all sitting, right? You just go for a more of the slouch positions, you all, and try to do the abduction. Can you able to do the abduction with the slouch posture? Or anything, even your flexion, can you able to do it? No. What is exactly happening? When with the slouch posture, if you go for the shoulder flexion or abduction, you can't able to do it because you're getting the impingement effect. Why? The scapula is going more towards the internal rotation and there's a less amount chances for the posterior tilt to occur. There's no posterior tilt happening because serratus is weak and the lower trapezius cannot able to pull in line because this is the lower traps, and lower traps cannot able to pull in line because already scapula has gone for the inward rotations. So that's what happens, when there is a weakness of the serratus anterior, and which will have an impact on that of the lower traps, and this leads to effect on the scapulohumeral rhythm. So you understood your scapular rhythm get altered because of these muscles, inhibition effect or the lack of action of these muscles. And again, second thing, suppose if there is a weakness of the lower traps muscles. If there is a weakness of the lower trapezius muscle, what happened? The angle of pull of this is reduced, means what exactly happened? There is a less chances for the posterior tilt to occur. At the end range, the last degree of abduction, you need to have the posterior tilt. When you go away from the 90 degrees of abduction, you need a posterior tilt. If there is no posterior tilt, again there is an impingement effect at the subacromial region, and it obstructs the movements. So again, it's very important the lower traps actions. So that's what when you think about scapular humeral rhythm, these three muscles, force couples, are very important. That is upper traps, the lower traps, and the serratus anterior force is very important. These three forces, how it works, this, like that these are the joint force couples, that is upper traps and the serratus anterior lower traps will assist for you to go for the the abductions or external rotation, and this one lower traps will assist for that of the posterior tilt, so that the obstructions going at the top of the subacromial regions can be prevented, and you can able to get the full amount of the flexion or the abductions. So in a short, I mean to say, upper traps and serratus anterior contributes for the movement of the movement of the shoulder, and the lower traps acts like a movement regulations, which is very important. It plays a major role whenever you move the shoulder abduction about the 90-degree positions. So why I wanted to discuss all this thing is because we need to know this, the scapular mobility or the role before going for the physiotherapy interventions. So in scapular dyskinesis, what exactly happens? This is what happens. In scapular dyskinesis, there will be a weakness, imbalance between the serratus anterior and upper trapezius causes the scapula to abnormally translate, causing the decreased upper rotations. So this is one of the reasons for getting that of the scapular dyskinesis. That means when I talk about the cause factors of the scapular dyskinesis, this is one of the main cause. The main cause for the abnormal motion of the scapula is due to that of the muscle alterations. So what are the muscle alteration is? It's because of the imbalance of the alteration of the muscles or the imbalance between that of the upper traps, lower traps, and the serratus anterior muscles. So whenever you had any shoulder injuries or anything pain comes, the first muscles to go for the inhibition is the serratus anterior muscles. Followed by that, the sequence of changes takes place and leads to this, leads to impingement effect, and consequently it leads to that of rotator cuff tear, labral tear. Like this, it keeps on goes. Next, other causative factors of the scapular dyskinesis. There are other causative factors of scapular dyskinesis is pectoralis minor tightness. It is one of the major cause for another major cause for scapular dyskinesis. Whenever there is a pectoralis minor tightness, what happens? The coracoid process will be pushed forward. That means there is a more amount of anterior tilt of the scapula, which again, obstruct the shoulder movement, leads to that of the shoulder injuries. And the last, the other factors is another factors for flexibility issue is the capsular tightness. So when there is a weakness of serratus anterior, when there is a weakness of lower traps, when there is a there's a more internal rotation of the scapula, there's a tendency of the posterior capsules to become more tight. When the posterior capsules become more tight, it pushes or translates the humeral head more anteriorly, decreases the subacromial spaces, and gives more amount of impinging effect, leads to that of the shoulder injuries. So these are all the causative factors for the scapular dyskinesis leading to the shoulder injuries. So S.I.C Scapula is again a type of scapular dyskinesis, comes under type 1, where there is a scapular malposition. S means, I means inferior medial prominence is there, C means coracoid pain, and the K for the nothing but dyskinesis, which I will be showing you in the next slides. So now you understood about like what exactly the normal movement of scapula, and if the scapular movement is altered, how it affects on that of scapular humeral rhythm, and what all the main muscles contribute for maintaining the scapular's the movements. These are things you understood now. Let us go on the scapular dyskinesis types. What are the different types of malposition of the scapulas? So according to the Kibler et al., he has shown he has he has classified the 3 types of scapular dyskinesis: type 1, type 2, and type 3. In type 1, there is a prominence of the inferior, medial border of the scapula, you can see. Type 2, there is a more prominence on the medial border of the scapula. And type 3, there is a more prominence on the superior medial border of the scapulas. So the type 1, it is basically nothing but inferior angle tilt posteriorly, and it is and the patients will have a coracoid tenderness due to the tight pectoralis minor, as I told you before, and there will be inferior medial border prominence will be there like this. So what is the reason behind? As I told you, there will be because of the pectoralis muscle tightness is the main causative factors for the type 1 dyskinesis, and there's weakness of the muscles of both. You will have it. Slowly it may weakness of muscles like serratus anterior, lower traps, which I just now discussed it. So, but like type 1, type 2, type 3 dyskinesis, whatever the Kibler et al. Has told, the inter-rater reliability of these things are very less, and it's very difficult to classify the person whether it is type 1, type 2, type 3, because most of the time it's a mixture of all the 3 things. We can't clearly predict from the visual analysis that the patient has got only type 1 or type 2, which is very rarely you can able to see the type of classification, or the patients we can able to tell that, yeah, he has got type 1, he has got type 2, or he has got type 3. Most of the time there will be a mixture of type 1, type 2, or type 2 or the type 3, because as we discussed till now, because there's a more problem of these dyskinesis because of the muscle imbalance, which is correlate each other, or which is related each other. So type 2 dyskinesis, where there is a medial scapular border dysfunctions, you can see the medial border is more prominent, and transverse plane interrotation of the scapula is there. This is purely because of the weakness of the serratus anterior muscles, and this in turn leads to the posterior capsular tightness also. So when it comes to the treatment part, yeah, generalized, I'm told you here, like you have to work on that of serratus anterior. We have to work on the stretching of that of posterior capsule. So when it comes to the type 3 type of scapular dyskinesis, it's something like this, where there is a prominence of the superior medial border of the scapula. This is due to that of the tightness of the levator scapulae. And there will be more shrugging of the shoulder will be there in type 3 scapular dyskinesis. And here the physiotherapy role will come for stretching of that of the levator scapulae, and the strengthening of the muscles of the lower traps and the serratus anterior muscles. So, but like as I told you, it's very difficult to in my clinical experience, and as I've gone through the references, they say like it's very difficult to tell like yes, the patient has got type 2 or the type 1. More time it is both will be there. So till now you understood about the type of scapular dyskinesis. Now let us discuss on how this scapular dyskinesis is relation to the shoulder pain in scientific evidence ways. Okay, there are a lot of studies has done by Anna Kuhl, because in this presentations I've taken the references of main 2 persons, that is Ann Kuhl and Webb Kibler. They have done a lot of studies of on scapular dyskinesis part, which I'm in my presentation I've taken the references from them. Most of my slides consist of. This is the important thing when it comes to that of scientific. If you want to scientific evidence how the scapular dyskinesis is related to the shoulder pain. You see this slide. What exactly this slide shows? If you see the person of 3 types in the groups, if they're taken, they are healthy person, impingement person, glenohumeral joints instability person, and the adhesive capsulitis person. Especially this has been published in the journal JOS PT 2009 by Ludwig. He has shown that abnormal scapular orientation kinematics in 3 groups, what they have found is, in the case of, as I discussed you, in the case of normal healthy person, the primary scapular motion is upper rotation, fine. But in the case of impingement rotator cuff shoulder patient, this is what they have seen. They have seen in the case of impingement shoulder, there is a less upward rotation of the scapula. So in the case of in an impingement shoulder, they have shown there's a less posterior tilting of the scapula. And in the case of the impingement shoulder, they've shown there's a greater internal rotation of the scapula. So that means in the impingement of the rotator cuff tendonitis patients or the impingement of shoulder, these are the three abnormal motions you have been seen. They have seen, and that is the major cause for getting the impingement of the shoulder. So that means if the patient comes to you with the impingement shoulder, you need to work on this rather than going directly on the glenohumeral joint motion. Suppose if these motions you're not, stabilized, that means you don't work on, if you want to maintain, the normal scapular motions to occur, that is your upper rotation, your posterior tilt, external rotation, means you need these muscles to activate. That is the upper traps, the lower traps, and the serratus should activate together. If these are not activating, this is what happening, and this in turn leads to the impingement. So what generally we do, we don't work on this one. We directly go on the glenohumeral joint motions of muscles. Mainly you are the not axioscapular muscles. You go for directly of the scapulohumeral muscles. That will lead something like rotator cuff muscles. So what exactly happens if you go directly on the rotator cuff muscles? Even your rotator cuff normal muscles, the normal length tension will varies because your scapula is not well stabilized. When your scapula is not well stabilized, what happens to your rotator cuff, your supraspinatus? Is it a normal length tension? No, your length tension of the muscles varies. It reduces. Your length tension is reduces. Either it go for insufficiency, like it may go for that of active insufficiency. With that, what happens? Your normal push of your rotator cuff to pull the humeral head backward, it cannot able to do it. In that case, it leads to that of what happens? Your humeral head tends to translate more towards superiorly, and you will start getting the impingement. You understood? So that is where this is what happens in the case of the impingement shoulder. This is what they have shown, and it's very important for us to get back these motions rather than going directly on the glenohumeral joint motions. And the same study also shown other structures like glenohumeral joint instability. When the patient comes to the glenohumeral instability, this is what they have shown. There's a less upward rotations. Okay, there's a less upward rotation. There's no consistent evidence of alteration of posterior tilt is not there, but there's a greater internal rotations. So that means when you have a glenohumeral joint instability, there is a lesser upward rotation. So when there is a lesser upward rotation, what exactly happens? When there is a greater internal rotations. When there's a greater internal rotation, the scapula tends to move more inward. There's the acromion will start getting downwards. Okay. And there's a more anterior tilt is there. And when that leads to posterior capsular tightness, when the posterior capsular tightness leads to superior translation of the humerus, when the superior translation of humerus leads to what? Greater stretch comes on that of the ligaments. Anterior coracoid, your glenohumeral ligaments will start overstretch. Your capsules will start overstretch anteriorly, and it leads to the instability. So that means these are all the movements, inconsistent movement leading to the joint instability. Whereas in the case of adhesive capsulitis, what exactly happened? There's a greater upward rotation because the capsule is tight. When you ask the patient to do the abduction in the case of adhesive capsule, what will happen? There's a more upward rotation, but yeah, there is no dissociations between that of the glenohumeral and the scapular, because there's a reverse scapulohumeral rhythm is taking place. So that is the different things. So this is the scientific evidence clearly showing how the scapular dyskinesis leading to these conditions. So as I told you, impingement syndrome is basically due to these two things: abnormal humeral translation, lack of the scapular stability and the mobility. Just now when I discussed just now, this is what it's related. As I just now I discussed the same thing. What exactly happened when there is a force couple imbalance? This, as I told you, when there is a imbalance between that of like lower traps and that of serratus anterior, there is a more chances of getting that of instead of going for the posterior tilt, going for anterior tilt, there is a more chances for the shoulder, scapula to go for internal rotation, reduces the joint space, leading to the impingement effect. And also, as I told you, when these muscles are weak, the normal movement or the normal length of your rotator cuff muscle, like your supraspinatus, your infraspinatus muscles, normal length will change because there's no stability from the scapula by these muscles. So when this happens, what happens? The normal negative translatory pull from the rotator cuff will be decreases. When the negative translatory pull from the muscles of the rotator cuff decrease because there's a less stability from the scapula, there's a more anterior translation of the humeral leading to the impingement. You understood? So these are how you're getting the impingement of the shoulder joint because of these factors. That is because of the lack of the scapular mobility or the stability part. So according to the Kibler et al., he has mentioned, this is how he has mentioned about how you get the impingement. So same thing as I told you, according to the Kibler et al., the scapular position of less upward rotation, increase internal rotation protraction commonly seen in the impingement, as I showed you the last slide. This will have an inhibition effect of the serratus anterior activation and will have an increased upper trapezius activity. This is very important. When there is a serratus anterior weakness comes, what happens? There's a more activation of the upper trapezius. This is what you have seen many times in the patients of impingement shoulder. There's a more activation of the upper trapezius. So because same reason, when there's a lower traps is weak or serratus anterior weak, this load is purely taken by the upper traps. When the upper trapezius activity increases, there is a shrugging. Because the whole why it is shrugging, because it cannot able to pull the acromion upward. There's a more of shrugging is taking place. It cannot able to move the acromion process upward. So that leads to what? There'll be there's a decreased lower trapezius activations. There'll be scapular winging, loss of acromion elevation, posterior tilt, and this also reason. And last one is the pectoralis minor tightness will contribute to that of the impingement of shoulder. That is, these are all the combined together. One is serratus anterior inhibitions, over trapezius activity more. When the over trapezius activity more, there's a decrease in the lower trapezius activity. When there's a lesser on the lower trapezius activity, there's a lesser amount of the posterior tilt of the scapula. When there is a lesser posterior tilt of the scapula, there's a more amount of the anterior tilt of the scapula. That is again correlate with the more amount of pectoralis minor tightness and reducing the subacromial space, leading to the impingement of the shoulder. So this is how the muscle imbalance due to that of scapular mobility and stability leading to the impingement of the shoulder. So another reason for impingement of shoulder is GIRD, that is glenohumeral internal rotation deficient. This is again the same thing. When there's a muscle imbalance, there's a posterior capsular tightness. When there's a more posterior capsular tightness, what exactly happens? If you ask the patient to do the internal rotations, he cannot able to do it. There will be restriction because of the superior translation of the humeral. So there will be a GIRD. This GIRD effect will leads to decrease in the subacromial space, increases the pressure on that of the supraspinatus tendon, leads to the what you call impingement syndrome. And the last evidence they say is lack of scapular retraction. As I told you, the scapular retraction position is the optimal position for the scapular movement, because the retraction of the scapula is very important, because when there's a retraction of scapula, there is the optimal position. This is the optimal position because your rotator cuff muscle will be in the optimal position to move the humeral properly. If the scapula is not retracted, if you protract and do the abduction, like the muscles of rotator cuff cannot able to move your humeral properly because it's not in a proper length. So that means it needs to have a a good retractor, scapular retraction position is very important. Why this is I'm talking about is in the case of overhead athletes, when you're serving the ball, this is the optimal position. Retracting position of the scapula is very important. If that is not maintained, it will lead to the impingement of the shoulder. So many times we think retraction of the scapula is mainly means you can able to retract like this. No, when you do want to do the proper retraction, there should be a linkage from these things. That is, you should have a good control from the core, you should have a good control from the hip. Then only you can maintain the proper retraction position, which I'll discuss you in the later slides. So that's what, so when these changes happens, that is stability, mobility changes, you will end up with the rotator cuff tear. How the rotator cuff tear comes because of scapular dyskinesis? As I mentioned, when there is these motions, that is external rotation, upper rotation, the posterior tilt reduces, or when there is a decrease in the subacromial space, what exactly happening? The rotator rotator cuff will go for a abnormal compression force repetitively, and leads to that of the tear of the rotator cuff muscles. Or as I told you, when there is a lesser what you called posterior tilt, or when there is a more anterior tilt is there, what exactly happening? I told you, when there's a more anterior tilt, there's a posterior capsular tightness. When there's a posterior capsular tightness, what happens? The humerel will translate more anteriorly. When it translates more anteriorly, what exactly happens? With that, the overhead athletes, if you start throwing the ball with this scapular dyskinesis, what exactly happens? There's a more compressions comes at the labrum, which leads to the injuries to the labrum. There's a more stretch comes on the glenohumeral ligaments, and this in turn leads to decrease in the strength of the rotator cuff. In turn leads to that of tear in that of the rotator cuff in progression. It may lead to that of rotator cuff tear. All these things changes takes place. That means your instability is happening initially, that slowly progress to that of the rotator cuff tear. So overall, I say this scapular dyskinesis, these movements, that is a restriction in the movement of upper rotation, external rotation, and posterior tilt, leading to glenohumeral joint, the instability, and in turn leading to that of the rotator cuff tear or the labral tear. Okay, there is a scientific evidence showing that scapular dyskinesis leading to cervical pain, or there is a relationship between the cervical pain and the scapular dyskinesis. So increased cervical and thoracic curves and slouch posture affect the scapular orientation, shoulder muscle strength, and the shoulder range of motion. This is what the Anna Kuhl has told. Like whenever there is a slouch posture, it affects the scapular orientations, scapular muscle strength, and scapular range of motion. In turn, have an impact on the cervical region or the curvature of the cervical region. What I want to say is, like, suppose if you have the slouch posture, okay, when there is a so this is what I want to say. When you have a slouch posture, what exactly happening in the slouch posture? When you have a slouch posture, the scapula will tends to go more amount of what exactly there is a the scapula will go more abducted positions. There is a more anterior tilt will be there. So when there's a more anterior tilt of the scapula, so what exactly? There's a more tightness. There's a more protraction of the scapula. So when there's a more protraction of the scapula, what exactly happens? There's a more the tightness of the pectoralis minor muscles. It leads a stress on that of the cervical deep cervical flexors will get affected. It can't able to maintain the normal tension to make your your cervical regions to go for the extension. So that leads to strain on that of the cervical region, leading to the pain on that of the cervical regions. This is how scapular dyskinesis leads to that of the cervical pain. So many times, the patient comes to me with the pain in that of the cervical regions. We work only on this, the muscles of, controlling the cervical region. We work on strengthening the deep cervical flexors, extensor, without considering these things. No, whenever the patient comes to you with the problem of cervical, the pathology, we need to consider this. If you don't consider it, if you act directly, the muscles cannot able to act because the muscle length tension varied because there is no stability from the scapula. So it's very important, the scapula to be well stabilized before working on that of the neck muscles. Because if these muscles are weak, it's going to affect more on that of the cervical regions. So there are some studies shown this one. Before that, I can show you the research. What is showing is when you have a rounded shoulder, that is forward posture, slouch posture, this is what they found. They found that there will be shortening of the pectoralis minor, as I told you. There's a 7 degrees less external rotations of the scapula. There's a 6 degrees less upper rotation of the scapula. There is 7 degrees less posterior tilt of the scapula. So when the person comes with the slouch posture, this is what the changes you can expect in the scapular movement. Are the changes of a person in the scapular movement of in the person comes to you with a slouch posture. So with this, so much of changes is there. When there is a changes, what exactly happening? As I told you, when there is these changes happen, there will be more amount of these muscles will start overactivating. That is, pectoralis minor will start overactivating because the more protraction of the scapula, and the length of the normal length of this cervical muscle will changes, and this in turn leads to a strain on that of the cervical region. Even there is the study shown it affects on that of the muscles of the normal, the spinal nerves, which is coming out, the brachial plexus, which is situated here, will get in abnormal tension, and this itself will lead to the radiculopathy or the pain. Many times we think the problem is coming from the cervical region. No, the problem is coming from cervical region, fine, but why? It's because they don't have the good control from the scapular regions. So many times I treated the patient where worked on the scapular muscles, and the tension on these things has released. The patient has released his pain, his radiations pain, and all those things. This is my the clinical perspective, and this is my experience. Not only my experience, this is some of the studies clearly shows, like effect of scapular functional training and chronic neck pain in neck shoulder regions. This study clearly shown, like SFT, that is scapular functional training, reduces the pain intensity and increases the shoulder elevation strength in adults with chronic non-specific pain in the neck or the shoulder region. So this is what these studies clearly shows, that when the patient comes to you with the the effect on the problem with the cervical regions, work on that of your scapular functional training is very important. If you don't work on the scapular functional training, if you work purely on the cervical region, you may not get the proper results. So whenever you're assessing or treating the patient of cervical region, it's very important to think on the scapular motions. So there was also some studies shown that linking of scapular muscle dysfunction leading to the lateral epicondylitis also, that is tennis elbow. So we have seen like how it is related, when these muscles like lower traps, serratus anterior become weak, when there's the more amount of internal rotation of the scapula, there is a overactivation of the upper trapezius, and where there's a study has shown, investigator found induced pain at the upper trapezius appears to produce increase in the wrist extensor EMG activities in the healthy individuals, even in the patients who doesn't have any problems. And when they have done the study, they found that when the person have got upper trapezius overactivities more, there will be increase in that of the wrist extensor activity. Why it is more means, this is what the sequence says. When there is a diminished scapular control, there is a loss of dynamic scapular stabilization. When there's a loss of dynamic stabilization, rotator cuff insufficiency, as I told you, because the normal length of the scapula changes. This will lead to that of loss of range of motion and strength of the shoulder, as I told you. When there's a loss of motion of range of shoulder, is the what will happen? If you want to pick any object also from the down, you will start using more of the wrist extensor muscles. That is the distal segment, right? More, because the proximal segment is your scapula. When the scapula is weak, when the muscles is not controlled, the load directly goes from the shoulder to the elbow and leads to that of stress on the the elbow regions. That is, the muscles of your wrist extensor will start overactivity and leads to the epicondylitis. So even in the clinical perspective, in my experience, I have done in a case study where I found like when I worked on the scapular muscles properly, I could able to reduce the intensity of pain of the lateral epicondylitis. There was a patient who came to me with the lateral epicondylitis, where I analyzed, assessed the scapula. There was the scapular type 1 and type 2 was prominent, but his pain was on the wrist. But when I worked on these scapular muscles well, and I found there was a good improvement in the reduction of the pain in that of the elbow region. That is, the epicondylitis pain is reduced when I worked on that of the scapular regions. So this was my one of the case study, and this is I got the the literature review backup for this the case study also. The last role of the scapular dyskinesis is how it as I told you, like it's a kinetic chain link. The fourth role of the scapula is the proximal to distal sequence of velocity, energy, and the force of shoulder functions. It's a role is it has got the role to move the force from the whatever the force is generating from that of the lower leg, the trunk, and it's going to that of the shoulder is passing through the scapula. So that means its role is transferring of your force from the distal segment towards the proximal segment. It acts like a bridge. Okay, so scapula assists in transferring the large force, high energy from the lower extremity, back, trunk to the arm to the hands. This is how it functions. This is another role of the scapula. This is very important when you want to treat the kinetic chain link. Is very important. I'll be discussing you later. So this is the function of the last function of the scapula. So what happens when there is a normal link chain, that is the chain link between these muscles, like when the force generating from the lower limb muscles, it has to be transferred through that of the trunk. Suppose if the trunk muscle is weak, whatever the load the force is generated from here, if it's not passing properly through the trunk, means what happens? It will affect to that of the scapula. If the scapular normal movement will affect. When its normal movement affects, it's affect on the shoulder joint. It affects on that of the distal segment like wrist, and leads to the shoulder injuries or the elbow injuries also. So it's very important whenever you're treating the patient, you need to think on this part also, which I'll discuss you later. So see the video of the Shoaib Akhtar. When you see the video of the Shoaib Akhtar, you can see like when you're coming to the phase of the bowling, that is, you see this is the acceleration to the deceleration phase. When you're coming, you see the movement. When you can see the movement of the placement of the lower limb, that is your foot. You see when you're placing the foot more, because like the Shoaib Akhtar history, you've seen like he has got so much of instability of the ankle joint, and he is prone to get lot time the injuries of the ankle joint. So in this case, you see there is when it's the rear leg, you see there in the rear leg, when you place the foot, you see there's a more twisting of the tough ankle. When the more twisting of the ankle, what happens? Whatever the force is generating from the lower limb, it's not properly passing through the normal line. The force, whatever generate, is going abnormally to the hip joint. And when it go abnormally to the hip joint, what happens? He has to compensate more on the trunk. When he's compensating more on the trunk, what is happening to the scapula? The scapular movement will change, affected more on the shoulder. So that's what he prone to get he got the injuries on the shoulder because of the same reason. So because of the ankle instability is problem, the force which is generated is not properly passing through the scapula. When it is not passing through the scapula, when the scapula was got altered, there was a more anterior translation of humerel. Stressed is stress is labrum, stressed on his rotator cuff, and ended up with the rotator cuff injuries. So like this, like that's where the scapula, how the role is this one, like and that is how the scapula plays a role for transferring of the force from the lower extremity to that of the upper extremity. And that is what it's very important when you're treating the patients. It's not necessarily when shoulder means you need to think only on the shoulder. All these things, chain link is important. If the chain link, normal chain link changes, it will affect on the normal scapular movement. It will affect on that of the shoulder mobility later. So this is the shoulder funnel functions, kinetic chain. That is the force coming from the leg. It has to pass to the core, and scapula acts like a funnel to transfer the force to the glenohumeral joint and to the arm. This is what I want to say. The proximal stability should be known before going for the distal mobility. That means proximal stability means scapula. If the proximal stability is less, the distal mobility of your shoulder, the elbow will get affected. So for the proximal stability, if you consider this for the scapula, the proximal stability again comes here. That is your core muscles and the hip muscle. If there is any problem of these things, it will have an impact on the scapula also. So this is what most of the times supraspinatus is put on a trial for a problem with the shoulder when scapular muscles are to blame. So many times this is what the supraspinatus is put on trial. It is something like a wire, it's put on a trial for a problem with the shoulder when scapular muscles are to blame. So the scapular muscles will not put on trial problem, supraspinatus will not be put on trial problem when the scapula is well stabilized. So what if you can't, this is what till now what I said is very important to observe the movement of a patient on these ways, on these views, whenever you're going for the shoulder rehabilitation. So when you're going for shoulder rehabilitation, just don't go for directly for the shoulder external rotations and all those things. You have to observe it on all the aspects, okay? And then you plan for that of the treatment. So let us now, you understood what to be observed and what is the role of the scapula, what are the things to be considered, your muscles to be considered, and you understood what scientific evidence says why the scapular movements is very important to prevent the injuries. You understood just till now. Now it's easy for you to think about that of the rehabilitation part of the scapular, your physiotherapy intervention for the scapular dyskinesis region. So when it comes to the rehabilitations part, this is what I've been seeing, many times when the patient comes to the shoulder pathology, we always go with the, with the dumbbells going for the shoulder flexions, shrugging of the shoulder. Is it right? You're going for the shrugging of the shoulder when the patient comes to with the shoulder injuries. If you have impingement shoulder, if impingement shoulder, is it right to go for the tough shrugging of the shoulder? If the patient comes to you with the impingement shoulder, do you want to start with this type of exercises? You want to start with this type of external rotator directly? No. At least now, after understanding all these things, no. Whenever the patient comes to you with the impingement shoulder or the glenohumeral joint instability or the labrum injury, it's very important to concentrate on these things. That means what we see till now is when there's a scapular dyskinesis, when there's alteration is there, it's very important for us to get back the normal force couple. That means there will be a hyperactivation of the or overaction of the upper trapezius will be there. We need to inhibit that one. We have to activate we have to retrain the muscles of the lower traps and the serratus anterior. This should be our goal. Our goal of exercise should be to activate the middle trapezius, lower trapezius, serratus anterior, and to inhibit the overactivation of the upper trapezius. This should be our goal of our treatment when the patient comes to you with the scapular dyskinesis. What I want to say is it's very important to work on the axioscapular muscles rather than you're directly going for that of the scapulohumeral muscles or the axioscapular muscles directly. So generally, this is what we do. We do directly work on the scapulohumeral muscles. We go for external rotation directly for the shoulder. Just imagine if your scapula is not well stabilized, you're going for external rotation, you're increasing the stress on the shoulder joint. Okay. So when it comes to that of the rehabilitation protocol for the scapular dyskinesis, So this is what Anna Kuhl has proposed on the scapulohumeral. When patient comes to its scapular, dyskinesis, you have to go through something called scapular rehab algorithm, which is proposed by Anna Kuhl in 2010. And what does it mean is, it is something like what she says. If you think, it has divided into two parts, the left and the right. Left refers to that of the lack of soft tissue flexibility, and right refers to the lack of the muscle performance. That means when the patient comes to you with the problem of scapular dyskinesis, we have to analyze, as I discussed till now, we have to analyze what is the problem for the patient, whether he has got a problem with the flexibility part, whether he has got a problem with the muscle performance problem. So as she tells, like if you consider the sea lion with the ball, when the sea lion has to hold the ball properly, if there's a whips are there, you are pulling with the whips, we are pulling backward, means it's something like of the lack of tissue flexibility. When the whips are more, what will happen? It will pulls the sea lions backward. This relates to that of the tissue flexibility. And the muscle performance. Muscle performance refers to that of the movement of this part of the sea lion. If the sea lion's performance of this is good, it can able to maintain it. This refers to that of the muscle performance. So when there is a tissue flexibility is less, so that is we have to check out what is the problem, whether it's a problem with the tissue flexibility or soft tissue flexibility, or for the lack of the performance. So if it is of the lack of tissue flexibility, what are the muscles which will go for the the flexibility lack? We already discussed earlier in the slides. The main muscles which will go for the lack of flexibility is the levator scapula, pectoralis minor muscles. In case of, as we see in a type 1 and type 2, dyskinesis, we already discussed, we have to stretch those muscles. And there's another reason for the tissue flexibility will be the tightness of the infraspinatus, or the posterior capsular tightness is one of the reason for leading to that of the pain in that of the shoulder. So in that case, we have to stretch the posterior capsules. So according to her, they have done a lot of studies, and there's something called Bonstart et al. This is what generally we do. The patient comes to you with a case of tightness of the pectoralis minor. We always tell to go for that of doorway stretch. So, but in the cadaver studies, it's fine. They found it is good to do this doorway stretch in this position. Abduction, keeping the abduction in the shoulder in the abduction for 90 degrees, exrotation, and going for the stretch is fine. But if the patient comes to you with the impingement shoulder or the problem with the shoulder pathology, is it right to do this one? If you do it when you're basically aggravating the symptoms. In that case, it is ideally what she has suggested, and what they have done a study. They found like when you do the acromion process, when you move this coracoid process, the passively away, or if you move the coracoid process more posteriorly and hold it for a few seconds, that is a good stretch for the pectoralis minor. And they found the result is almost both same. Like they have taken the swimmers and they did the stretch, healthy swimmers. After doing the swimming, they made two groups and they checked that of the pectoralis minor's length. They found that index. They checked it, and the index seems to be the same. It seems to be they found to be same length. So what does the study found that when the patient comes to you with the impingement shoulder pathology, better to avoid this. Go for this type of the stretch, which will give a good result and which will assist you to overcome from the provocating factors for the pain and all. It can be reduced. And second thing, according to Anna et al, like sleeper stretch is the ideal stretch to stretch that of the posterior capsules. We have a modified sleeper stretch nowadays, which you can use it. And they also showed like how when you do this along with the sleeper stretch, when you do the joint mobilizations along with that, we found a significant improvement in the reduction of the pain on the shoulder. The patients who come with the impingement pain, they found there's a significant reduction of the pain where after doing this, the sleeper stretch and the joint mobilization technique they have done. So what is that, how it was affected and why it was affected? They found like, according to the Cool et al., they have done a study. They found like when you do this sleeper stretch position, when you push, stretch the posterior capsule, and when you did the joint mobilizations, after this they have checked that of the distance between that of the superior humeral head and with the subacromial space, the distance they have found. They found the distance has increased after doing the stretch. So that means GARD effect is reduced and the space is increased, and with that, the impingement effect has reduced, and the patient that the pain also has come down. This is what the conclusion of the study found. So the patient comes to you with impingement shoulder because of GARD effect. If you do these stretches, they found a significant improvement because of when you do this, there will be an increase in the distance between that of suprahumeral region to the subacromial space, that the region distance increases, and thereby the mobility is more, and we can able to prevent the impingement pain. Okay, so that's what the Anna et al. told. Anna et al. has found in the left side, if the patient comes to you with these problems, that is with the tissue flexibility or the tightness of the posterior capsules, you can go for all these techniques. Also, there are a lot of studies shown like soft tissue manipulations. Like many times we think only of the capsular tightness and all. No, many times there will be facial tightness. We need to work on the fascia. When you do this facial stretch along with these things, they found very great improvement, because facial stretch not only helpful for this, it also assisted for the good activation for that of the muscle also indirectly. Okay. So the second, that is the right side part of the algorithms, shows about the lack of muscle performance. Suppose the patient comes to you with these problems, lack of muscle performance. In that, there is a two types of patients you can get. The first patients will be like muscle control problem. The another patient could be the muscle strength control problem. Muscle control problem means these are the patients who have the good strength of the muscles, but they don't have the good coordinations of the muscles. What muscles I'm talking is about the same muscles, like force couple muscles, like the upper traps, the lower traps, and serratus anterior. Also, they have got a good strength, but they are not coordinating themselves. They are not coordinating the activating co-contractions of these muscle forces are not activated. In that cases, it's very important to get the conscious muscle control of the muscles. We have to get that is where we need to work on the neuromuscular coordination of the muscles. Nothing but you have to get the conscious control of the muscles. Okay, so that is very important. There is another type of set of people comes where they have a good coordination of muscles, but they have a weakness of or there is an imbalance of the strength of the muscles. That means there is a upper traps overactivity, lower traps weak, or there is a balance ratio between the upper traps, lower traps, and the serratus anteriors. Maybe changes is there. That time we should have to work on the strength training programs. Okay, so we have to analyze, we have to check what category the patient comes, whether it's the patient is coming this control, this type. Accordingly, we have to go for the treatment. We have to plan over the treatment protocols. So whatever it is, whether it is for the neuromuscular problem, or muscle control problem, or the muscle strength problem, first intervention when there's a problem with the muscle problem is conscious muscle control is very important. When the patient comes to you with the shoulder pathology, start with that of problem with that of muscle problem. Start with that of conscious muscle control activity. What do you mean by conscious muscle control activity? It's nothing but you're able to perform, the subjects are able to perform consistent movement of scapula into posterior tilt and upper rotations. So that means it's simple. We'll ask the patient, you keep a hand at the coracoid process and ask the patient to try to push in such a way that the coracoid process should go away from the finger, from the hand. So when you go away from the finger and hand, what exactly happens? You're trying to move your scapula going more towards the posterior tilt. Okay, you ask the patient to go for the more of posterior tilt and followed by the upper rotations. So posterior tilt and upper rotations. So that we have to teach. This is very important. And there are a lot of studies show there's a high correlation between the assisted and unassisted exercise. What do you mean by assisted and unassisted exercise means? According to the Anatol, they have done a study. They found like when they train this patient, assisted means first they train the patient assisted in the clinical setup, then unassisted, that is asked when you clearly train the patient. After that, you ask the patient to do himself in the house for a few weeks. And after that, when they saw the patient after 1 or 2 weeks, they found there's significant improvement in the reduction of the pain and improving the range of motions. I'll show you my clinical experience on this one. So this is the video of showing that the patient of, he had a rotator cuff tear and underwent labral tear, and he has underwent the, rotator cuff repair and the labral repair. And initially when he came to me, say about like after 6 or 8 weeks, after this 8 weeks of the post, the operation surgical intervention, he had a severe hiking of upper trapezius. He was overacting and he was not able to do the proper flexion and abduction. Although this is one of the muscle control problem, he had a good strength. If I ask him to do the side, side flexion and ask him to do the external, he was able to do the external, but he was not able to lift the hand. He was not able to lift the, shoulder. He was not able to do the shoulder flexion and abduction properly. Then I made for him to go for the conscious muscle control training. This is very important for any patient comes to a post-operative shoulder surgery. It's very important to start with the conscious control of scapula initially. If you don't do it, patients slowly start with that of, shoulder shrugging movement. When its shoulder shrugging movement starts, upper trapezius starts, it's very difficult for you to get back to the normal. Okay, I'll show you this patient. Okay, the video, see this. I trained him such a way like, this is what I was telling you, something called the posterior. We have to go for tilting of the scapula posteriorly and upper rotation of the scapula. See, you can able to do the flexion well if you do it. See, in this phase, he was not doing properly. There was a lower trapeze activity. And I told him again to do it. See, there's a posterior tilt followed by there's a posterior tilt and followed by upper rotation. He can able to do it more easily. So this is very important. Because when you do the posterior tilt, I already told you what exactly happens. When you do the posterior tilt, when you do the external, the scapula will be in a well optimal position so that the muscles of your rotator cuff can able to move free properly. So this is another example. He had same thing. He had a intertuberal stiff. He had a greater tubercle fracture, and he had a rotator cuff tear totally. So in this case, also see like what I was in the plane of scapula, I was just doing this one. See, I'm keeping the scapula in optimal positions. You can see optimal position of scapula, retracted position, skip posterior tilting of scapula followed by that of upper rotation. I assisted him. With that, he was able to do the movement easily. So this is what I want to show you, like how this is very important. Conscious control of muscle is very important before doing any sort of exercise for when the patient comes to scapular dyskinesis. Yeah, I trained him such a way that he was not able to lift properly because he is not doing it properly right now. Because that's what. So it's very important. I told him to do the scapula to keep it in a first you have to keep the posterior tilt. Then go for the upper rotation of the scapula. This we have to teach the patient whenever the patient comes to you with any proper type of the scapular dyskinesis you're treating. Okay, next intervention comes is if you want to improve the neuromuscular control, it's very important to emphasize on the close kinematic type of exercises. Okay, examples is something called the scapular clock positions. So when it comes to scapular clock positions or 12 o'clock or the 3 o'clock positions, you can see when you do the scapular 12 o'clock position, that is fix the distal segment and ask the patient to move the scapula more downwards. When you do it, what happens? We are increasing the neuromuscular control of the lower traps muscles, de-emphasizing the activation of the upper traps muscles. So this is how we have to get the neuromuscular control exercise. Or we can go for 3 o'clock positions to activate the lower traps, or to activate the more on that of the rhomboidus muscles. You can activate like this. So this is how you can do the exercises to improve the neuromuscular. Again, Anna et al. Has found like, like if you want to do any of the later, if you want to do the strengthening of the muscles of the retractors or whatever it is, it's very important to do the conscious muscle control and do the exercises. Example, like this is what she has found, and according to Anna et al., these are the exercise where we found like lesser upper trapezius activity, and there's a good activation of that of your middle trapezius and the lower trapezius activities. So especially like sideline position, sideline forward flexion, sideline extension, prone abduction and extension. These are all the position they have found very effective in decreasing the activity of the upper trapezius and increasing the activity of the lower traps and the serratus anterior. But they have done a study. They have done a study with conscious muscle control. So they have done a study with conscious muscle control. When they do it, they found is very more effective in activation of the lower traps and serratus anterior, overcoming the action of the upper trapezius. So what did the study found? Like whenever you're doing these type of activities or whenever you're doing these type of exercise, start with conscious muscle control. That is, pull the scapula backward. That is, you pull the scapula posteriorly, and then do these exercises. Then they found there's a more activation or the more control of these muscles, the lower traps, serratus anterior, and the more, there was a less activation of that of the upper trapezius activities. So that's what they shared. Presetting exercises increases the lower traps and the middle trapezius activity during the exercise. So this is very important. Presetting of scapular exercise, that is conscious muscle control exercise, is very important when you are doing the shoulder exercises. The next one is, it's very important to go for integrated functional kinetic chain rehabilitation exercise intervention. As I already showed you the video of Shoabaktar and all those things, because many times when you do the assessment of the shoulder, it's very important to see all the link. Nowadays, there's something called in the assessment of the shoulder. You heard about the Jeremy Lewis. He has come up with a protocol called something called shoulder symptom. The provocation test is there. So the shoulder symptom modification test is coming, like, so where shoulder symptom modification test has got a more assistance for checking that of the impingement shoulder or the rotator cuff tendon, rather than going for the normal test, like we go for the empty can test and all these things. In that test, he also found something called important to check these things. Like he has made to do the standing on one leg. He has made the standing patients to they go for this one leg squatting position to check the scapula, to check the shoulder motion. If the person has got the weakness of the hip abductors, it has got an impact on that of the trunk. It has got an impact on that of shoulder. So many times the shoulder pathology comes because of these problems, weakness from these regions. So it's very important to analyze it. And when it comes to the treatment protocol or treatment approach, we have to work in the same way. Integrated approach is very important. It's not necessarily only for the the overhead athletes or for athletes only this integrated approach. Even for the normal shoulder, patient comes to you with the normal shoulder pain, we have to go for the integrated approach. The reason I'm telling you. So in the there's a scientific So in scientific evidence for kinetic chain exercises, that is as I showed you, there is a lot of the influence of body position has got an impact on the kinetic chain exercises. So which I'll be showing you if there is a change in that of limb position, how it is going to affect these things. I'll show in the next slides. So this is one of the slide which tells you like how the the movement of the trunk or the lower limb affect on that of the shoulder movement. Example of this one, according to this Menhan et al., lower extremity position influence the scapular muscle recruitment and muscle balance ratio in a closed kinetic chain. This is the closed kinetic chain exercise. They found like if you just activate that of contralateral leg, if you activate on that of the contralateral leg, in the closed chain activity, there is a more activations of the middle trapezius and the lower trapezius activity they are found. So that means the activation of that of the lower limb or the trunk have got an impact on that of the scapular muscles. So this is how it is related. You know, the kinetic chain link is related. We need to work on the closed kinematic chain exercises. In the open kinematic chain exercise also they are found. According to Anatole, they have done a lot of studies where they have done the open kinematic the movements by in this, you know, the normal squatting and keeping contralateral limb one forward and this, you know, the positions. They found when you keep the contralateral leg forward and in the diagonal pattern when you do it, there's a more recruitment of the activation of the lower trapezius activities and inhibition of the upper trapezius activity compared to the other positions. That means what does it shows? When you go for the integrated approach, it's always better to, in the open kinematic chain exercise, if you're going, it's always better to go in a diagonal pattern of exercises. So this is a simple examples show you like what exactly happens. You see this example in the tennis servers, when you're serving the tennis players while serving, if this is the normal knee flexion is very important. At least it should not be less than 10 degrees. If the tennis server is serving the ball with less the degree of knee flexion, it will have an impact. When there's a less knee flexion, what happens? There is a when there's a less knee flexions, there is a more the loading effect on that of the trunk will varies. This is the normal knee flexion is okay. When there's a normal knee flexion, see there's a good transfer of the force from that of the lower trunk to that of the hip to that of the rotators, and there'll be a proper, let's say this is the example. You see there's a knee flexions is more, there's a good rear tilt of that of the shoulder comes. If the knee flexion is less, what exactly happens? Shoulder lateral rear tilt will reduces. Why it is reduces means there's a compensation changes takes place, because when there's less knee flexion, there is a less knee hip flexions. When there is less hip flexion, there's a more compensation takes place from the trunk. There is a more compensation trunk flexion. There's the normal movement of the scapula changes, and it leads to that of the shoulder injuries. And that's why this is the integrated how the this chain important. And when you're treating the patient, the integrated approach is also the important. So when you're going for the integrated kinetic chain approaches, it's very important initially to think of once any patient comes to you with the shoulder pathologies. When you want to go for integrated approach, it's very important to think on the what you call the core muscles. The core muscles we have to activate. Many times we neglect it. If you neglect the core muscles, this is what happens. See, that's just example. If you want to lift something from the floor. If you want to lift something from the floor, we think it's only the movement is taken care by that of shoulder. Is it from the shoulder? When it lifts something first, if you're doing the task like taking a bottle from the floor, what exactly happened? The movement is a sequence of motion. It's starting from the top hip. It's starting from the leg, going to the hip. The trunk is going for extension, moving the scapula. And this is how the force is making you to take the object from the down, from the floor to the above. Suppose if there's any link changes, is there what happen? Even a small task, the patient who has an impingement shoulder, even if you ask them to take a small task, like take the things from the top of the bed, it's difficult for them. But at the same time, if you just make the diagonal pattern and ask them to do the movement, they can able to do easily. Okay, so even many times the patient, when they have a weakness of the core muscles, this normal chain link will varies and leads to the problem. So it's very important to work on the core muscles. If the core muscle control is not there, it will have impact on the scapula. So before going for the integrated approach, it's very important to get back the flexibility, which I already told you, how to stretch the pectoralis minor, how to stretch the posterior capsules. And second phase of integrated approach is these are all the exercises. They are told something called robbery exercises. Why this robbery exercise is very important. And I just wanted to show you the video. Okay. So
Producer, we have to stop the share.
So I think
Then
it's okay. See, if you want to,
yeah, that's fine.
you can see, sir. Okay. See, this is the integrated approach. One is called the lawnmower exercises. So you can able to see. Hello. Okay. So in the lawnmower exercise, this is what's happening. You know, like we keep it in the same phase. You know, PNF, the diagonal phases. Contralateral leg is kept forward, and this is what we do. You keep the hands forward like this. When you do the forward like this, what is exactly happening? There's a more activation of the serratus anterior. And followed by sequence of motion, when it comes, what exactly happens? The force is coming from the top of the hip. The trunk is going for the extensions. See, it's very important, thoracic extension, for the scapula to get the normal movement. See, this is what happens, sequence of motion. The hip extension, trunk extension, thoracic extension, scapula is going for the retraction or downwards, and external rotation. This is the sequence of motion of the lawnmower exercises. So we teach the patients. The patient comes to you with the problem of impingement shoulder. After getting the conscious muscle control, you have to go for the integrated approach. And we found is very good effect because the loading on the stress going on the top of the supraspinatus tendon or rotator cuff is very minimal, because when you do the sequence of motion of exercises, you're getting back the force is generating from where? From the trunk, scapula, and all those things. You know, the less stress is going on the top of on the muscles. And the muscles will be in the optimal, you know, the scapula will be in optimal functions to facilitate the muscles to act properly. So there's another.
Sorry, please continue. Continue. Sir.
There's another activity, something called the robbery exercises. So robbery exercise is something like this. Okay. So where the same thing in the we will ask the patient to keep the hands, you know, to go like this. This is again, it's activating forward serratus anterior muscles, and the lower limb muscles are activating now. Okay, your knee is in flexion, hip is in flexion, and you ask the patient to go for the extension. Extension of what? You're going for that of hip extension, knee extension, trunk extension, followed by that of the retraction of the soft scapula. So what is actually happening? This is again an integrated approach. So your force is generating from the lower trunk, lower limb, passing to the upper trunk, getting back the scapular position, and moving the scapula backward. You know, like it's easy, and the patients can able to do it well. Following by that, if you do the normal, you know, external rotator activities, it's always better. So always, when it comes to scapular dyskinesis, when it comes, always go with the integrated approach. And you know, you can slowly go for the, in a sequential base, you can progress it. In the same lawnmower exercise, you can go with resistance with the dumbbells later. Even with the, what do you call, for the robbery exercise also, you can go with that of the resistance later. So this is the examples of the one of the integrated approach, open kinematic way you can do it to get the good control of the scapular muscles. So yeah, I think you can see my slide.
Yes, yes, sir.
So this is what I was talking about, lawnmower exercise, and so their studies have shown like lawnmower exercise, keeping the elbow low, activated serratus and to higher level, increasing 80%, while other muscles remain less than 20% stage. That means there's a more activation of the serratus anterior muscles when you go with that of the lawnmower exercise. This is what I showed you about the robbery exercises. So again, rotator cuff strength increased 24% when scapula stabilized and retracted. Should focus on scapular strengthening in an attempt to restore normal scapular kinematic rather than placing early emphasis on the rotator cuff strengthening as performed in the traditional rehabilitation protocol. This is what I was telling you. Never go with that of normal external rotation. Go with the integrated approach. You will get the optimal position of scapula well. Use these muscles before going for that of the directly on the rotator cuff muscle actions. And it's very important to go for the closed kinetic chain approach, the exercises. rather than going for the open kinematic chain exercise initially, because we want to de-emphasize the action of the upper trapezius. So it's many studies have shown like better to start with that of the closed kinematic, because it has got so many, has got so much effect. One is it activates the periarticular mechanoreceptors, improves your joint proprioceptors, and second thing is de-emphasizing on the muscles which is overactivity. That is especially in the scapular discus, overactivity is coming from where? From the upper traps. So we need to de-emphasize it. We need to de-emphasize. It's very important to have a exercise which have got a less rotatory translatory force. So especially when you go with that of the closed kinematic chain exercise, there's a less rotatory translatory force, and it will de-emphasize on that of the abnormal action of the muscles, and we can able to activate the muscles easily. So that is the advantage of using that of the closed kinematic chain exercise. So example of this, that's what there's a lot of studies shown why the closed kinematic chain is better to go rather than for the upper kinematic exercise. Because there are some studies have seen like when you go with the closed kinematic chain, the activation of the middle trapezius, serratus anterior, upper trapezius is more, and lower trapezius is more compared to that of the upper trapezius. When you do the same thing with upper open kinematic chain exercise, there was a less activation of that of the lower trapezius, but there's a more activation of the upper trapezius. So if you want to de-emphasize the upper trapezius, it's always better to start with the closed kinematic chain exercise. So example of this closed kinematic exercise is we have something called low row exercises, or like this low row movements. So it's something like you can fix the hand, keep the leg in a contralateral positions, and try to shift the body weight forward. So when you shift the body weight forward, or when you do like this, what exactly happens in this position? So there is the force is coming from that of the muscles from that of hip abductors, extensors, and it gives the optimal position of the scapula and assists the good activation of the muscles of that of lower traps, and the serratus anterior activations will be better. Not exact certain, lower traps activations are higher when you do this exercise. And even there are some studies, even like Kibler et al. Have shown, like some patients, if you just activate the glutes muscles and core muscles and fix the hand and try to retract the scapula, we can able to retract well, or we can able to push the scapula well, rather than if you don't hold these muscles, or if you don't keep it in a this contralateral position. If you try to do it, it's very difficult to do it. So it's very important to maintain the diagonal position and activate on this. And distal, this one, the closed kinematic chain is very important because you can able to emphasize more on the muscles, and we can de-emphasize on the scapular muscle or of your upper trapezius muscle. Another example of closed kinematic chain exercise, low row exercises. So low row exercise also shown to be very effective in activating the lower traps muscles, rhomboidus muscles, and de-emphasizing the action of the upper trapezius muscles. So when it comes to this slide, as I showed you, and at all coming to this this thing, so it is very important first to get the conscious control, then work on that of the advanced basic control exercise activities. That's what we have to work on, the integrated approach. And when it comes to the conscious muscle control ratios, we have to balance it. When it comes to balancing, we have to work first with the closed kinematic exercises first. This is how we should have to go when you want to go for the strength training of the muscles. And lastly, the very important exercise in the closed kinematic chain exercise, the push-up plus. Push-up plus is one of the important exercises to activate. If you want to activate the serratus anterior well, if you want more activations, it's very important to go with the push-up plus position, not push-up, push-up plus. So where this is the end range, end movement of the push-up plus. In the end movement of the push-up plus, there will be more activation of the serratus anterior movements. So this is what they've shown, like when you do the closed kinematic exercises with a different approach. Suppose if you do the closed kinematic exercises with contralateral leg, there will be 20% activation of more activation of that. We have found highest activation of the middle trapezius and lower trapezius and lower trapezius activities. And there is, if you go with that of the ipsilateral leg activities, this is the ratio. They found there's a more activation of the serratus anterior activities compared to that of the other muscles. So it depends like what you want to do. So you want the more activation of the serratus anterior in the closed kinematic chain, you go with that of the ipsilateral leg. If you want to go activations more of that of the middle trapezius and lower trapezius, you go with that of the contralateral leg. The other open kinematic chain, later we can go for the open kinematic chain exercises with the resistance. So if you want to activate the serratus anterior, the dynamic hug is found to be very effective to activate the serratus anterior muscles. This is the exercise performed in different angles, especially at 120-degree flexion. They found serratus anterior punch, that is dynamic hug, is found to be very effective in activating serratus anterior muscles. And these are some of the exercise for the infraspinatus and the lower traps muscles, open kinematic. So it's very important. Kinetic chain movements is very important. That is, trunk rotations increases the scapular muscle recruitment, as I showed you earlier, and the recruitment of lower extremity trunk increases the activation of the scapular muscles, as I showed you in the exercise like lawn mover and the exercise like robbery. So later, rhythmic stabilizations exercise, and the closed kinematics we can go challenging with the wobble boards and all these things. So later, this is all the challenging exercise. You can do it later phases. So it's very important conscious muscle control, followed by that of getting the balanced ratio of the upper traps, lower traps, and then go for the complex exercises, whatever. It depends. If it is for the athletes, we need to go with the more of functionally related to the sports specific activities. So in summary, never go for these type of exercises. We always tell the patient, patient comes to you, we tell the patient to go for these exnotations like this. No, don't go for shrugging exercise. Don't go for this exercise unless you get proper scapular control. And always close kinetic chain except starts with that of close kinematic exercise. The closed chain exercise promotes the co-contrast rotator cuff muscles at submaximal level. So that means never go with that of the open kinematic high weights initially, rather than going for the closed kinematic exercise when the patient comes to you with the shoulder pathology. So there are a lot of studies have shown like scapular muscle rehabilitation improves the pain functions in a patient with mild impingement syndromes. And these are all the studies. These are all the studies by Anatol has found like 12 weeks program of scapular exercise improves the isochondric muscle strength, muscle imbalance, muscle balance in healthy adolescent swimmers. They also found like 6 months of program of scapular retraction exercise improves the rotator cuff strength, especially the infraspinatus in a volleyball players. What does this slide shows like? Even if the patients, if the athletes, the overhead athletes, they have the scapular dyskinesis, if you found, even though they don't have the symptoms, it's very important to work on the scapular muscles, muscle strength, to prevent them to go for this type of the injury. And not only it prevents the injuries, it will assist for the performance also. So this is another study from the Anatol. She has told scapular exercise improves the muscle strength and symptoms and relative muscle activity in over athletes with impingement symptoms. So they have found like by doing the scapular exercises, what we have just now discussed, it helps to not only improve the muscle strength and it improves the muscle strength symptoms, it reduces the symptoms and also helped in muscle strength as well as relative muscle activities, performance activity in the athletes. So this is what my like I did a research review, the research study on scapular type 2 scapular dyskinesis. And this is what I applied. I applied the technique like like robbery, lawnmower exercise, and close kinetic chain exercise for the patient, and found very effective in overcome from the pain symptoms, and also to improving that of their functional activities. This is one of the simple case study I can show you there. If you see the patient, this patient has comes to me, like age group of only 20 to 23 years old. And if you see him, you think that they diagnosed him as a rotator cuff, as a adhesive capsulitis. I don't think the adhesive capsulitis are the frozen shoulder. You can't expect it in the case of this age group, we all know. But what made him to go for the restriction of the motion? You can see there is a restriction of the flexion and the abduction of this patient. You can see when I analyzed him, this is what I found. You see, when I asked him to do for the abduction, the medial border of the scapula is going away. There was something called the scapula, the normal, the external rotation is not taking place, and the normal, the scapula normal outward rotation is affecting. This is making him to go for more upper trapezius activity. This reducing the subequimoral space and giving him the more amount of the impingement effect and pain on the shoulder. Not only pain, he is obstructing the movement. So what we did was 6 weeks we went for the training of the scapular muscles, and taping is not really just don't do only the taping. Taping will facilitate for the muscle, but no research studies has clearly shown like the taping itself will assist for this one. No, we did the scapular activities, and taping along with adjunct to the treatment we applied it to assist or facilitate the muscles. And later this is what we found after 6 weeks of the training of scapular muscle training with the taping. We found he has got a significant improvement in the shoulder movement. You can see there's a abduction is improved, and even he can able to hold the shoulder in a proper line, without straining more on the upper trapezius. Even 90 degrees he can able to hold it. So that clearly shows the scapular training plays a very important role. So this is what after 6 weeks you see is normal movement. The lower traps is able to activate well, and the less stress is going on that of the upper trapezius. This is one of the case where he had a complete rotator cuff tear, and he was not able to lift also. So I just trained more on the scapular muscles initially. The same thing we tried within the range, whatever we can able to activate, facilitate the serratus anterior lower traps, we trained in the same way. And following of the 6 or 8 weeks, this is what we found. He was able to abduct and is able to maintain the position of the shoulder for abductions. That means scapular control role is very important. When the patient comes to you with the shoulder pathology, if you control it well, these things, at least we can able to maintain his. Even though he has got a complete tear of rotator cuff tear, but using this scapular stability, you can able to, do a little bit of the activity of the shoulder, which he was not able to do for so many months together. So this much I could able to expected this patient. The patient could able to do the functional activity. This is almost like 10 weeks to 12 weeks of the rehabilitation protocol on scapular muscles. I found. After 12 weeks, he could able to raise the shoulder up to the 90 degrees or above, but not probably more than that, because since he had the tear was more, and he was seeking for the the operation intervention to overcome this problem. So take-home message is, so always emphasize on these exercises. The close kinematic exercise, integrated approach is very important when you're treating the patient with scapular dyskinesis. And these are all the basic exercise we have to do it whenever the patient comes to you with any type of the shoulder pathology. And these 4 exercises are found to be very effective in activating the lower traps, serratus anterior, and de-emphasizing the activation of the serratus, your upper trapezius. So message 2 is focus on muscle balance rather than muscle strength. So don't work on the muscle strength, rather than you should have to focus on the muscle balance. So third is always remember kinetic chain approach is very important. So whenever you're treating the patient with the patient comes to you with the shoulder pathology, your approach should be of the kinetic chain links, because your scapular movement depends upon the distal segment. If the distal segment is weaker, it will have an impact on the scapular movement. So it is very important. If you can't see it, you can't fix it. So it's very important to see, observe, analyze, and then treat it properly. These are all the references I have taken. And more references I've taken from the Twanakul and Ben Kepler. They have done a lot of studies on the scapular dyskinesis. And this is the main things you want to keep it in simple. Think of these muscles whenever you're treating the patient of the shoulder pathology. Thank you so much. It's my thank you so much, JSS College of Physiotherapy, for giving me the opportunity to present in this platform. Thank you so much.
Thank you, Pradeep sir. It was a wonderful presentation. You started with kinematics, kinetics, and it was very important that you emphasized on the integral function of kinematic chain rehabilitation. So it was really a wonderful presentation, and you put an insight on the scapular stability, which many places, many times, many of them miss during rotator cuff injuries, and they concentrate only on the rotator cuff muscles. And you have just given an insight on the importance of the scapular muscles as well as the scapular function. So it was a good presentation, sir. And I just would like to take some few questions.
Yes, sir.
Yes, sir. So here there are few questions on the anterior muscles. That's mainly with reference to the anterior compartment of shoulder muscles with pectoralis minor. So they're asking about the tightness of these muscles anterior. How does it affect the scapular movement and also cause the scapular dyskinesis?
Yeah, it's an important question. Like as I mentioned earlier, the main muscles. That's what when you're working on the scapular dyskinesis or when you're working on the shoulder pathology, the major muscles which will go for the tightness or flexibility lack will be the pectoralis minor muscles. When there's a pectoralis minor muscle is very tight or more tight, there will be more anterior tilt of the scapula. So when there's a more anterior tilt of the scapula, what exactly happens? Your subacromial space will be reduced. It leads to the impingement of the shoulder. So it's very important to think on the flexibility of the pectoralis minor muscles. We have to stretch the pectoralis minor muscles when you're treating the patient with the scapular dyskinesis. These are anterior muscles. In the anterior part of the shoulder, you have to think on the pectoralis minor muscle, which is very important to be considered. Yeah.
Yes, sir. Thank you, sir. And also one more question, which is based on ribcage abnormalities like scoliosis.
Yes.
How is it related? Does scoliosis again lead into scapular dyskinesis? That was the question. So will scoliosis lead into scapular dyskinesis? And as well as the scoliotic person, in a scoliotic person, how do you assess the scapular dyskinesis?
Yeah, that's a good question. Definitely, like you have a scoliosis of type, different type. We have a C curve or S curve shape. So it depends. Like if it is a C curve shape, yeah, definitely there will be, as you've seen, like when there's a C curve shape, there's a more movements only in the lumbar part, where there is a convexity of one side, the concavity of the other side. So you can expect there's a tilting of the one side of the shoulder down, one side of the shoulder upward. So you can think like the shoulder which has been tilted downwards, and the one which has gone upward. The one which has gone upward, what you can expect there? The convexity side of scapula, definitely there will be more tilting towards the anteriorly. So you can expect the pathology of the shoulder on the side which has been tilted upward in the case of the C shape. When it comes to that of the shape of the S shape, again it varies. where exactly the tilt is there. Generally, you think on the places where there is a convexity side is there and the concavity side there. That you have to think of. And second thing is, see, as I told you, the core is very important. This is the distal segment. The distal segment is what? Is your lumbar part. If the lumbar part has got a changes, it has got an impact on that of the scapula. So don't think like one side there's upper rotation is the anterior, there's a more of anterior tilt is that there's a back. The other side there is a, you may think there's a scapula is going for the posterior tilt, but it has got an impact on the shoulder mobility because there will be a tightness of the latissimus muscles, latissimus dorsi, which will have impact again on that of the scapular depression position also. So many times we don't think only of scapula only in the phase of movement of acceleration phase or the upward movement. When you're coming downward, how the deceleration comes, how the eccentrically these muscles control is very important, where the action of the latissimus dorsi also plays an important role. So where the latissimus dorsi comes, it's come from the trunk. So that's what we see. There is, when there is a problem with the distal segment, it will have an impact on the proximal segment. So whether the scoliosis is C curve, whether it is scoliosis S curve, will have an impact on the scapula. And if you want to control the scapula, you can't control directly on the scapula. You have to work from the down. You have to work from the hip. You have to work from the leg. And you have to work on the core. Then only you have to come for the scapula.
Yes, sir. Thank you, sir. So this is one more question. So there is, with reference to your evaluation, the winging of scapula and the scapular dyskinesis. So how do you differentiate this?
I didn't get it. Winging of scapula and?
Winging of scapula and scapular dyskinesis. How do you differentiate?
How do you differentiate?
So this is, yeah, I got it, but this was the question which they wanted to hear from you.
Okay. Okay, fine. So see, the winging of scapula is nothing but it's because of the weakness of the serratus anterior muscles. As I mentioned in the type 2 type of scapular dyskinesis, maybe we have seen that in the slide. I mentioned in the slide, type 2 dyskinesis is nothing but there is a winging of scapula in the type 2 dyskinesis. When the Kibler et al. Has done the types of dyskinesis, type 1, type 2, and type 3. In type 2 dyskinesis is nothing but there is what you can see in the type 2 dyskinesis is there is a winging of the scapula. This is how we can, but we can't differentiate between the two. The winging of scapula is nothing but serratus anterior weakness, and this is what you can see in the type 2 type of dyskinesis. Okay, I'll show you that slide again. But how to differentiate? I didn't understand what exactly you want.
Okay, I think the attendee who's asked the question is meaning that with an impact of nerve injuries with the scapula, that is your scapula, mainly your serratus anterior weakness, purely coming with serratus anterior weakness.
When it comes to that of type 2 type of scapular dyskinesis, this is what I was telling about. So type 2 dyskinesis, this is what? There's a serratus anterior muscle weakness. So this muscle weakness, yeah, if you want to know the reason of getting this weakness, it can be the pathology of, one is muscle inhibition, second would be the the type, when there is a long thoracic nerve which is supplied to the your serratus anterior nerve, when it is injury is there, you can expect it like this type of type 2 type of dyskinesis, but not necessarily always to be the nerve injury pathology. I've seen many cases, like they have a type 2 dyskinesis where they don't have any pathology of that of the nerve part. It can happen because of the muscle inhibition effect. The first muscle which will go for the inhibition effect whenever you have a shoulder pain is the serratus anterior muscle. You can expect this winging of scapula not so much prominent, even mildly. The patient who comes to your post-rotator cuff repair patients, or even the impingement shoulder patient, you can see these patients.
Yes, sir. I think it's answered because most of the time the scapular muscles, that is your serratus anterior weakness, also have the component of winging of scapula, as well as can lead into a dyskinesis, right, during the movement. So that's what you need to concentrate, to differentiate, identify, and go with reference to your evaluation and treatment.
Yeah.
Yes, sir. I think we have done with it. One more is last question. I'll just take it because of lack of time. Do you use muscle energy techniques in scapular dyskinesis? How effective it is?
Yeah, definitely. When I was talking about the Anakul's algorithm things, okay, uh, regarding this Anakul's rhythm algorithm, see, when it comes to that of see, muscle energy technique is required what when we want to inhibit reflex inhibition of the overactivity muscles, and we have to activate that of the muscles which is weaker. That is what it works on, the muscle energy techniques. So suppose you're working on the muscle energy technique. Yeah, suppose the patient comes to you with more tightness of the pectoralis muscle, tightness is there, and we need to facilitate the muscle of the lower traps. So yeah, you can go for that of the muscle energy technique for levator scapula. You can go for the muscle energy technique for the pectoralis minor muscles, depending upon the type of you have the scapular dyskinesis. And followed by that, you can go for the activation of the muscle which is weaker. Like you want to facilitate. Suppose the patient comes to you with a type 1 type of scapular dyskinesis, where there's a pectoralis minor tightness. You go for muscle energy technique for pectoralis minor muscles, give more of resistance, followed by that of activation of that of the opposing muscles, the retractors. So it will help you. So that way we can use it. Same thing, type 3 type of dyskinesis, when the levator scapular tightness is there, you go for muscle energy technique of on the levator scapula and work on that of the other muscles. So that's what she told, like Anakul et al. When you have the patient have a soft tissue flexibility is there, we have to not only she mentioned only the stretching, all your soft tissue mobilization technique, your muscle energy technique can be applied in this phase.
Yes, I think it's answered. And so we have one last question. I'll take up this one question. Is it reliable to always consider the glenohumeral rhythm, that is 1:2? Is it needed that to consider always? Is it reliable?
Again, the scapular humeral rhythm. That's what I wanted to tell you something like in this my presentations, I have not gone more depth on the assessment part of the scapular dyskinesis part, which is very important, and because of shortage of time. Again, scapular humeral rhythm. It's like see again the scapular movement, three-dimensional motions. Okay, and it's till now it's very difficult to find out the proper rotation, where exactly the external rotation is taking place, when it is going in the posterior tilt. They have done the studies, lot of things, but we can't predict like what exactly the movement is taking place of the scapular, in which phase, in which movement, and which rotations. No, but yeah, scapular rhythm, humeral rhythm, you need to be consider, and it is to be considered any times, because this is what we need. We have been gone through the studies, and we have been gone through these are basic things. When we have to be know it, whenever the patient comes to you, the patient cannot able to do the abduction of the shoulder, when you don't do the flexion of the shoulder, we go for observation, we go for the assessment, right? When you go for the observation and when you go for the assessment, we think on that way. Where is the problem? In which part of the rhythm is getting affecting? That is what we hypothesize, and then we go for the treatment part. In that aspect, we have to think. It is very important to know the scapular rhythm, humeral rhythm. So you'll come to know where exactly the problem is. Suppose the patient cannot able to do the abduction, say about from the 90-degree above, and he has got the full all muscle is good, but he is not able to move above. It could be because of that of the muscular control lack of the lower traps, or there is a lack of the control of the scapular movement, especially like posterior tilt and all. So that way it will assist you to know before going for the intervention.
Yes. Thank you, sir. Thank you for the wonderful session, and you have spent a lot of time with the demonstration and with explaining more of with reference to its assessment as well as the treatment part. and it was really an informative. And on behalf of JSS College of Physiotherapy, the organizing team, the principal, Dr. Kavita Raja, on behalf of all the staff, faculty, students, and on remembrance of this international webinar series, I wholeheartedly thank you for being with us and sharing your valuable knowledge and expertise, sir. Thank you, Pradeep, sir. And we're happy to have you here. Thank you, sir.
Thank you, Dr. Kavita Raja, Principal, College of Physiotherapy, organizing committee for giving me this opportunity. And yeah, being a family member of this, I was a family member of this JSS. It was a more emotional experience to be, like I'm more excited to take a sessions for the JSS College of Physiotherapy when I got this opportunity. Thank you so much. Hope all the students got some information regarding the scapular dyskinesis. Thank you so much, JSS College of Physiotherapy, for giving the opportunity. Thank you, sir. Thank you. Thank you, Vijay.
Thank you, sir. Thank you, sir. Thank you all participants for joining this session.